Musculoskeletal trauma, presented by Dr. Stephen Masharia, General and Trauma Surgeon. The objectives of this lecture are to learn about the significance of musculoskeletal injury in the multiple injury patient, identify life and limb-threatening injuries, and learn the management principles of extremity trauma. Musculoskeletal injuries are quite dramatic and usually attract our attention to the detriment of the airway, breathing, and circulation. 85% of multiple injured patients usually have a musculoskeletal injury, and this is associated with a significant internal injury and bleeding, both soft tissue and bony. Life and limb-threatening complications can follow musculoskeletal injury, and we need to be aware of this, and we need to re-evaluate the patient, especially in situations where certain complications can arise. As always, we manage the patient following the ABC priorities, that is airway, breathing, and circulation. And in circulation, when there is musculoskeletal injury, it can result in significant blood loss. For example, a fracture femur can result in the loss of 1 to 2 units of blood, and pelvic fractures result in even more severe blood loss. To control hemorrhage and pain initially, we need to splint, and that is an important first aid measure. And x-rays are the best way of evaluating musculoskeletal injuries, and so we must order them early. The views that we order for injured patients, just to remind ourselves, are a cross-table lateral C-spine x-ray, an anterior-posterior x-ray of the chest, anterior-posterior x-ray of the pelvis, and of any limbs that are injured as indicated. And remember, when we evaluate and we do x-rays for limbs, we must do the x-rays of joints above and below as well. In the secondary survey, we take an ample history, and then we examine the patient, and in examination, on inspection, we are interested in what wounds or swellings or deformities there are. In palpation, we palpate for tenderness, for crepitus, we check pulses, sensation, and whether the limb is warm or cold. An injury when the extremity is cold might imply that vascular supply is compromised. And we also check movements, normal movements at the joints, and also abnormal movements, which might indicate fractures. In extremity trauma, threats to life can result from pelvic disruption because of severe bleeding and visceral injury leading to sepsis, major arterial hemorrhage from, say, bony fragments injuring major arteries, crash syndrome resulting in extensive damage to muscle leading to rhabdomyolysis, and that can precipitate acute renal failure. Fat embolism is a rare but serious complication which will affect respiration and is common in long bone fractures. And limb-threatening injuries are, for example, open fractures and dislocations because of risk of infection, vascular injuries, and even traumatic amputations. Of course, the latter can also be life-threatening. Compartment syndrome, a common, usually quite insidious problem that we may need to look out specifically for. And neurologic injuries, especially common in dislocations. For example, posterior dislocation of the femur can cause a sciatic nerve injury. Manifestations of vascular injury are pallor, pulselessness, paresthesia, pain, and paralysis. 5 P's, very important to remember. Nerve injury can manifest itself with numbness or loss of sensation in an area and loss of motor function. For example, foot drop in common peroneal nerve injury, wrist drop in radial nerve injury, and claw hand in ulnar nerve injury. Compartment syndrome is a common and insidious problem that requires high index of suspicion, and it results from an increase in pressure within a fascial compartment of a limb, and this leads to reduced blood supply because of compression of the arteries and causes distal ischemia and distal loss of function. Hypotension will also, of course, contribute to compartment syndrome, in that if there is a bit of pressure and the blood pressure itself is low, then distal perfusion is affected, even if the pressure may not be very high in the compartment. Common causes of compartment syndrome are fractures, crush injuries, reperfusion injury. This is situations where there is arterial blockage or arterial injury, which is then repaired, and then you can have scars if the limb is burnt, and sometimes the casts we put to treat fractures can be the cause of compartment syndrome. And compartment syndrome manifests itself with swelling, with pain, pallor, paresthesia, that is as a result of ischemia and neurovascular damage or compromise. Tenderness on passive movement, that is quite important sign to elicit, and the management is to relieve the pressure, usually surgically, by doing emergency fasciotomy. True orthopedic emergencies are rare, but they are very important to note because they are usually limb-threatening, sometimes even life-threatening. And these are, for example, fracture with loss of a pulse, which signifies vascular injury, hip dislocation, knee dislocation, or ankle dislocation. This can lead to, in some cases like hip dislocation, avascular necrosis, and in the other cases, osteoarthritis after repair, severe osteoarthritis, and sepsis, of course. Spinal fractures with neurological deficit and compartment syndrome is an orthopedic emergency. These X-rays show a dislocation of the knee, and management of musculoskeletal injuries. First of all, we must achieve hemodynamic stability, because most limb injuries might compromise circulation. C is a major priority in this, and if it's a dislocation, we must reduce as soon as possible, usually after dealing with the immediately life-threatening injuries. And pain control is of absolute importance. This can be achieved usually by splinting and also by giving the necessary pain medication and even nerve blocks in some cases. In the secondary survey, any other element of the history that might suggest further injury should be explored. For example, if you have a calcaneal injury, you must look for injuries in the knee and in the lumbar spine. And there's some injuries that might be associated. For example, some complex injuries, if you have got a dislocation of the radioulnar joint, you must also look for a fracture either in the radius or in the ulnar, the so-called Monteggia and Galeazzi fractures. Pelvic fractures is a subtopic in itself, usually handled sometimes under abdominal injury, but we'll consider it here. Mechanisms for pelvic injury are, for example, high velocity motor vehicle crashes, very common, falls from great height, building collapses, and pedestrian accidents. And pelvic fractures lead to severe blood loss with hemorrhagic shock, and that is because the injury occurs in the pelvic bones, which are large cancellous bones and associated with great pelvic vessels like the common internal and external iliac arteries and veins. There is also significant visceral injury like a genitourinary injury, for example bladder rupture, and this can be intraperitoneal or extraperitoneal, best assessed by doing contrast studies. You can also have ureteric and urethral injuries. In fact, membranous urethral injury is a very common problem in pelvic fractures. Gastrointestinal injury is common. This affects the rectum or the sigmoid colon. Should be looked out for, and sometimes also the anus might be affected. Problems with genitourinary and gastrointestinal injuries is the resultant sepsis. Classification of pelvic fractures is according to the TILES classification. A stands for stable fractures, meaning there is no disruption to the integrity of the pelvis. This might be as a result of only a fracture in one area, not a serious injury, not a very serious injury, but significant nevertheless. B, fractures that disrupt the ring of the pelvis, that's open book fractures, and this result in, if you have a fracture in the horizontal plane, a fracture in the pubic symphysis, and posteriorly in one of the areas as well. And C, which is the most serious, you have got both rotatory and vertical instability, that is displacement of one side of the pelvis vertically, as well as an injury to the pelvic ring. These are best shown in the diagram shown here. This picture and the X-ray below shows a fracture of the superior and inferior pubic rami, and also on the opposite side, superior pubic ramus injury. This is TILES A fracture, in that there is no posterior injury, and so it is not an unstable fracture. This X-ray shows a severe injury affecting the pelvic ring anteriorly and also the sacroiliac joint, and this is a severe injury, TILES C, because they're receiving displacement of one side of the pelvis vertically. Here there are the injuries of the pelvis as shown in the pictures corresponding. Fractures are usually described by describing the relationship of the fragments and the location, that is the bone and the part of the bone that is injured. And we should use the terms angulation, which can be either varus or valgus, as this diagram shows. And if there is significant displacement of the fragments, we must talk about it. And sometimes the distal fragment might be rotated. There might be shortening because of overlap of the fragments. And if it's joints we are describing, the dislocation might be partial, which we call subluxation, and complete, which is dislocation. Pediatric fractures deserve special mention because there are some differences. For example, because of incomplete ossification, long shaft fractures of the pediatrics might result in only a partial fracture, so-called a green stick fracture. And because of growing many growing ends epiphysis. Epiphyseal injuries are common and quite severe, and especially serious, with having serious repercussions on or effects on future growth, and so we must pay particular attention to them. And this is the Salter-Harris classification. Type 1 is only a slip through the growing plate. Type 2, there is, besides injury to the growing plate, there is also a fracture of the metaphysis as shown in the diagram. Type 3, we have the epiphysis and the physis, that is the growth plate, affected. Type 4, both the epiphysis and metaphysis are affected. And type 5, there is a serious injury to part or all of the growth plate because it is crushed. This is the most serious of the epiphyseal injuries and results in arrested growth of the limb with serious future effect, with the serious implications on growth. And these are x-rays. This is an x-ray of type 2 Salter-Harris injury. This x-ray shows is an example of an anterior dislocation of the shoulder, and it's the commonest kind of dislocation, and there are maneuvers to reduce this. For example, this is what is shown here: traction and counter-traction, or these Simpsons or hanging method, and the commonest in our setup is the Cocker's maneuver. This X-ray shows a Colles fracture, which results in a dinner fork deformity. It's a common fracture in the elderly, especially in women affected, and results from fracture or a fall from with an outstretched arm. Orthopedic referrals are recommended, actually important if you have any open fracture, any fracture with significant displacement, any intra-articular fractures, any fracture associated with a nerve or vascular injury, any suspected compartment syndrome, and if you have a supracondylar humeral fracture in children, this is an Salter-Harris injury and needs orthopedic referral. Useful regional blocks recommended for people conversant with the anatomy of this region. Of course, femoral nerve blocks can block the digits by doing lateral blocks at the bases of the digits. Radial ulnar median nerve blocks, and the best thing to do is to learn about these nerve blocks is to consult the appropriate anesthesia textbooks. In summary, therefore, the airway, breathing and circulation are still the priorities that we must pay attention to, and when we deal with extremity injuries, circulation is usually a significant consideration. We must look for and identify life and limb-threatening injuries and treat them accordingly. We must do the 3 X-rays in the primary survey, and besides, we must also do other X-rays as indicated. And remember, when we X-ray the limb, we must get X-ray the joint above and the joint below as well. Remember, some fractures have associated injuries, and if they are not obvious, we should look out for them. For example, calcaneal injury affecting the lumbar spine as well. And early referral is necessary.